So I will now request Professor Titiyal to come out with his second presentation, and as he has to go for the OPL, so we'll take up his second talk also, and he's going to talk on I got a PCR, then what to do.
Okay, I'll show you two videos how we manage the intraop posterior capsular dialysis happening in these cases. You can see this is a typical posterior polar cataract and how to handle these patients, and especially if you open the posterior capsule to begin with. So this is a typical onion peel appearance. This large center, almost 3.5 to 4 millimeter disc. And if you see the intraop OCT picture also, difficult to appreciate where is the posterior capsule. So this is a moth-eaten appearance. So I'll do a delineation, which is classically told. Delineation has to be done in these patients. So just see, I'm doing a delineation on one side. Just observe this particular part. I'm showing it again. So this is what happens in a high-risk case of posterior. Can you see that? I'll show it again now. Injector fluid. See the flutter happening in the posterior part. The posterior capsule are given way at that stage only. So in those cases, how do we handle these cases? Because now you have an open posterior capsule, but we have done a hydrodelineation. So you will be having an epicortical cushion to support that open area. So it is must that you don't rotate the nucleus or epinuclear complex at this stage and avoid the opening getting larger and drop happening in these cases. So what I'll say there is importance of making a small chop area and taking out the piece and allowing the fluid to get into your hydrodelineated area, making nucleus free. Without rotation you can manage. So what I'll do here, you can see I'm doing one chop here. So this piece will be taken off us. We are not rotating the nucleus here, and each piece will be taken layer by layer, and the entire piece has come out now. The nucleus has been taken out. This is the epicortex I'm trying to remove now. So you can see gently I'm taking out epicortex here. Entire bulk has come out. Now at this stage, you can see that there's a PCR already visible here. This is a tear area, but it is well maintained. If your irrigation well maintained, it will not open up. That this again you saw in the previous case, I'm injecting dispersive viscoelastic to maintain the space. Then go for a aspiration by these cases. So this is a stage you have the large opening in the posterior capsule, which you can see it is going like this. And the vitreous is not there. I've maintained the entire area with the dispersive viscoelastic. Now what should be the IOL implantation choice? Dr. Arvind, will you go for a 3-piece or you'll still go with a single-piece IOL here?
Because this particular case, you have a complete radial tear in the posterior capsule, and you have to be very careful because the 3-piece IOL would be the best. You can still put into the capsular bag, but only thing is your haptics have to be perpendicular to the tear. It should not be radial to the tear. It should be perpendicular, like it should on the opposite axis of the tear.
Okay, I think that's the one option we have, because I thought my opening is, it is there, but it is well stable, which normally happens in the posterior polar cataract unless you have a very, vigorous aspiration of fluid hydrating the vitreous face. So once you tamponade the vitreous face with the dispersive viscoelastic, the vitreous normally remains down. So I'm injecting the single piece IOL only. For that, I'll not inject wound assisted because that might, damage my area here. I enlarge the axis so that my nozzle of injector goes inside. I'll open the lens over the, anterior capsular axis margin and gently tuck the haptics behind without causing too much of a damage. And as rightly pointed out by Dr. Rajendra Prasad, I'll be putting lens like this. So that's the one option here. I'll fill the chamber with a dispersive viscoelastic. Now see how inside I am there. My lens will open over the iris, in fact, so that I don't damage the. Now gently tuck the optic inside and the haptic inside. So the both things have gone inside. Shift it towards the center. The little distortion has occurred in the posterior axis, but it is still intact. And this is because it's not a toric lens, so I'm not worried. This is not a multifocal lens, I'm not worried as such. So it's quite stable now. I'll form the chamber and quite stable. Leave some dispersive viscoelastic there to tamponade the vitreous phase. Nothing will happen. But if you want to be very sure, sometimes you might inject the triamcinolone in anterior chamber. See if the vitreous is there. You can do a removal of vitreous also. Any comments, Arvind?
Sir, do you prefer doing optic capture in such cases?
This is a case because it is a simple spherical IOL. I thought I can keep it anywhere; it will remain stable. So I'll show the next video. Then that will be much more answerable to you. This is the patient. Again, posterior polar, not posterior polar, but I've done a femtosecond laser device. So I'll open the all the chops here, then remove the entire nucleus. I'm doing a bimanual aspiration of cortex. So I left little bit of cortex because bimanual with the handpiece here, and I could not aspirate this part. I thought this cortex I'll aspirate subsequently and inject the IOL, and this was a trifocal Acrosop lens. So you can see I'm injecting the Helon now, which is sodium hyaluronate. Nice rexus. Injecting the trifocal lens. Very nicely it has gone inside. At this stage now I'll do an aspiration. I thought I'll just pull this cortex here. And as soon as I pull this cortex, entire capsule opened up. You can see the capsule opened from here to here. The entire half capsule is not there. And this is a toric, trifocal lens now. What to do? So I'm injecting dispersive viscoelastic just underneath the IOL margin. And from here also, so that it will tamponade. The idea here is I can't remove this lens. The idea here is to make a reverse optic capture of this particular IOL and tamponading the vitreous face with the dispersive viscoelastic. This is Biscoot from Alcon. No financial interest in this, but that's the one good viscoelastic here. Then I'll shift this optic anterior now. Just shift to this area and keep the cushion of viscoelastic there so that vitreous face doesn't come out. Again, now I'll go to other side. So the other side has to be lifted up. Inject the dispersive viscoelastic underneath the IOL margin. That will again form, then lift it up. You can see then the lens is quite stable here. Then I'll do a bimanual procedure to lift both optics sides up together. This is one side. Now I'll go from this side also and lift this up. So you can see this quadrangle shape has come up because haptic is behind and optic is upwards. Maintain the chamber and you can see the lens is nicely oriented, and this is the picture here. So this is how sometimes you can safeguard your this thing. This is the picture at the end of surgery. You can see a quadrangle shape. This is underneath the rexus margin. Optics are above the rexus margin. So sometimes if you don't have a vitreous coming up anteriorly, you can just save your day with the reverse optic capture also. Okay. I think I have the I don't have the pictures now. I did have the 1 year follow-up also. It's stable lens. And any comment what will happen to a post-op refractive error in this patient, Dr. Rajendra Prasad?
See, because now you have done the reverse optic capture. The first of all, we have to see the centering. It has to be, because since it's a trifocal IOL, in trifocal IOL, your centering is very, very important. And then the lens is going to be positioned little anteriorly. So you are going to have overcorrection. So you have to be ready for that. And but in a trifocal IOL, a little bit of overcorrection is always better, because patient will have a better near vision. May have a little compromise of the distance vision, but he'll definitely have a better near vision.
Absolutely true. And this patient already had a trifocal in other eye. This was second eye. And this was, I could achieve not very well center, but you can see these are, the Perkins images in the central area, and axis is also nicely oriented. Luckily, when this lens opened up, the lens was in a proper axis. If lens would have opened like this rotation per se would have damaged the remaining posterior capsule and would have created more problem for this patient. The patient did have a little 0.5 myopia and a post-op period, and but he had a good near intermediate vision. Despite that, he was quite comfortable. But because this lens opened inside the bag, then subsequently posterior capsule opened up. But if you have a posterior capsule opening beforehand and you're trying to do a reverse optic capture, then you should change your IOL power and go for another lens which has a slightly less power than a in the back power in your case, because this is like a lens kept in a sulcus. Okay, thank you. We can go to the next.
Thank you very much, Professor Titiyal, for the beautiful videos we have seen